Hello, welcome. My name is Julie Hirschberg. I am a neurologic PT from Reactive Physical Therapy. And if you haven't seen us before, Reactive Physical Therapy is a neurologic physical therapy and fitness practice. We help people who have neurologic disorders recover movement and strength and confidence. And we do that all through changing people's brains. So brain changing therapy and exercise. We do this as physical therapists, so one-on-one physical therapy, personal training. We have group exercise through yoga and educating other physical therapists. So that is us. And today I am so excited. I've been excited for over a week to share this. We're going to dive into the latest and greatest research in stroke rehabilitation. And the reason I've been so excited about this is because I have a great honor to be a part of teaching this, teaching part of the CPTA, which is the California Physical Therapy Association, part of their research symposium that they do every year. This year they did it about stroke. And let me just tell you, the people that were a part of this were just the leading researchers and clinicians in the field of stroke. And that includes people like Carolee Winstein, Dorian Rose, Nancy Beal, Natalia Sanchez, Allison McKenzie, Beth Fisher, Julie Tilson, like all of these wonderful leaders. And so the purpose was really to bring together the latest in stroke research, latest and greatest, maybe even stuff that's not quite prime time. So it was really fun to dive into what's happening and talk to other researchers, and then really work to apply it for our the people that we know who have had a stroke. So this was a whole weekend conference, and I could probably be here for like 3 hours going through some of the key points, but I tried to distill it down into the 5 easy take-home messages to kind of get you thinking. Some of the stuff was pretty thought-provoking, to be honest. Get you thinking about the way recovery might happen if you've had a stroke, and to go beyond kind of the traditional what you might be thinking of, and also to challenge the way you might be thinking about working with somebody who's had a stroke. So the first thing that was kind of one of the number ones was this idea of actual recovery versus compensation. And now I think on the surface, this can seem very obvious. Like, of course, we want people to recover, but how we practice this and how we measure this is very important. And the question really comes up, you know, as physical therapists, when we change function or we see an improvement in function, was that because there was recovery in the brain, or did that actually just happen due to a compensation? How do we know that recovery is occurring? And one of the first examples given here, and this was Carolee Winstein talked about this quite a bit, and we all feel this as physical therapists, 100%. Is pressure from insurance or regulatory agencies to get people through inpatient rehab fast and drive functional changes. I think this is especially clear. This was really clear when I worked in inpatient rehab. And now, you know, average lengths of stays are really short. So they're looking at something like the FIM, which is pure function. And, you know, Carolee really argued like it doesn't really get at whether there's actual brain recovery occurring. And there is a very beautiful book. I highly recommend it. It's by John Krakauer. It's called Broken Movement, The Neurobiology of Stroke Recovery. And I'll put a link in the comments here about it. Because Carolee had recommended this book to me. It's heavy. I'll let you know, it's really heavy neuroanatomy, neurophysiology, which actually kind of lights my brain up. But what is really nice in this book, it's a very recent book. I think he's out of Johns Hopkins. he has a very lovely review of years of literature from fundamental neuroscience, from rehab, and like neuroanatomy, like he's talking tracks and things like that, which it really, in a very geeky way, gets me super excited. But he argues from a rehab perspective that we need to both measure and influence change, not just in function, but in some of key underlying impairments, so that we can show that we are actually driving neuroplasticity and not just having people compensate. So for one of the examples was, we might, and I was part of a huge research trial that looked at changing gait speed. So we might look at changing somebody's gait speed, but if we see that, so they get faster, which is great. And yes, we want to drive these things, but do they also change in their motor control at all? And I think one thing is we need better measures of this for sure. The Fugl-Meyer is one way, and I think most of us would go, oh my gosh, not the Fugl-Meyer, it's so long and tedious. But that would be one way to show a change in motor control. This is controversial for sure. And he's not arguing that you just try to change somebody's movement pattern and not their function. So it's not like tipping the scale that way, but he is challenging us, and Carol Lee challenged us as rehab professionals to, if we're saying we're driving neuroplasticity, we need to measure it. And now, of course, there's some other things, and they talked about using direct brain measures, functional MRI, some of the transcranial magnetic stimulation, and using that as well. That's not ready for prime time. We're not using that in practice. But I think there are a lot of great things technology-wise that we can use, specific kinematic measures, force measures, using sensors and things like that that may show some of those changes. So recovery, not compensation, big one to show that we're driving neuroplasticity. Number two, and this goes right along with it, is what are some of the latest research in the interventions that drive recovery post-stroke. And I think a lot of us know some of these pieces of literature, but there were some really interesting things that came up. A couple of things were that optimal theory, and we've talked about this before, but bringing in a very specific biopsychosocial model to drive changes. And that includes not the what we do in therapy, but the how we do it. Are we providing autonomy, enhanced expectation, external cues? And there's some really nice literature coming out in stroke for using these and benefiting people's recovery and their motor learning post-stroke. There's some really cool work coming out of Delaware looking at fast walking with FES and using FES of the plantar flexors. And this is something I've actually done. And so it was interesting to see some of that literature and see the benefits of combining those things together. What some of the benefit was is really you could walk fast, you could do FES, but the combination of those things together can really improve people's gait speeds and their recovery, so their kinematics as well. Backward walking has been a huge area. Dorian Rose has some really nice studies in this area. She presented the very specific techniques as well, and they do a lot on the treadmill with backward walking and on uneven surfaces, up and down ramps. It looked really fun, to be honest. And it seems so simple also, but like super easy to add to practice. If we're not already. It's funny because I've had several patients go, I don't walk backwards. And I'm like, really? Let's actually have you go into the kitchen and let's see what happens. And that's where I find a lot of backwards walking personally happening myself. Backward walking in some of the things that Dorian showed was actually drove more changes in gait speed than forward walking. So there you go. I think we all need to add that in. we talked about the split belt treadmill. And I had the great privilege when we were preparing this to have Natalia Sanchez come into the clinic with me. And so she's doing some of this research at USC. And she had been at Northwestern as well. And she was like, look, you don't need a split belt treadmill, because I was like, look, I can't afford a split belt treadmill. And she's like, let's create the poor man split belt for you. And basically just using tape on the treadmill. And I think a lot of us already do this. It's a great external cue, but driving step length to improve symmetry just with a simple external cue. Maybe one step actually needs to be shorter and the other longer, and maybe you need to bias that and induce some errors. And that's part of the whole split belt paradigm. And you can do it at home with tape, and you can do it even over ground with tape to cue a step length. So that was really fun. That was something that we got to do together and present a case on that. Tape, it's like, you know, the number one tool, right? And then finally, we got to talk about some of the recent research coming out of the Cleveland Clinic. They have a pilot study right now where they did aerobic training prior to upper extremity training. And we saw a presentation about this at CSM this year. Really powerful stuff, looking at people having better results if they primed the brain. So they talked about this golden hour of like lovely neurotrophic factors after aerobic exercise, and then doing that task-specific exercise. So really cool stuff. I know I'm really trying to get all of my patients into aerobic exercise, and if we can time it right to do it before our therapy sessions, it's really powerful. It's not always practically working out right in the schedule. I know that is a barrier, but I think it can be very powerful. So look out for, that's an ongoing study, and I think we're going to see some cool results from that. Some other new and noteworthy stuff, and this is an area Nancy Beal really loves, and I love her for it. Maybe it's not quite ready for prime time, not huge randomized trial, but it's up and coming. We should look at it. One of them was the autonomic nervous system, testing it and treating it. And she showed a lot of lovely studies that looked at the autonomic nervous system really being quite affected after a stroke, more than we once understood. And that things can improve, especially if we measure things, measure heart rate variability, measure skin conductance. That was an interesting one. And this was one where Nancy Beal was like, yep, I'm, looking into I think maybe she actually purchased a skin conducting, a conductance test that can be done. And so this is up and coming. Should we be measuring this? I think this is something we need to start looking at. This is stuff that we talk about a lot with other disorders such as dystonia, functional movement disorders. But I honestly hadn't really thought about it in stroke. So I thought this was really exciting, and, training the autonomic nervous system, just like the rest of our nervous system. So this kind of went under that umbrella again of like recovery at every system level. So, so I'd be curious if people are testing this and treating it. And then number 4, this was some really cool work coming out of Caroline Winstein's lab, but this is all about exploring and exploiting and learning. And so this is like brand new, not even hot off the press, like it's going into publication. Caroline's graduate student, Andrew Hoyman, is doing this work on learning and has some interesting findings that Caroline applied post-stroke. We did a case with it as well. In particular, how we set up our interventions. In the study, they basically did a motor control task, a new task, where people had to find out and kind of learn the rule and then exploit it in order to do the test, to keep winning, essentially, kind of like learning a video game. And it turns out what they found is that there are people who explore really well. They try new things, they figure it out, and then they can exploit the rule and do really well with that. And there's other people that don't explore as much, and often it's because they haven't had this type of experience before. And what Carolee really pushed us all to think about is, how do we apply this idea to how we set up our treatments? Can we set up our treatments with lots of opportunities to explore, less cues from us, but a defined environment to try out new things? And whether that's different surfaces, how to tackle a new task. I think this is something we, as physical therapists, I think especially neuro PTs, we do kind of naturally do this. But I know for myself personally, I'm not sure I thought about it quite in this way. Setting up exploration, understanding somebody as an explorer too. Some of my patients who are really fearful are less likely to explore, and I need to carefully set that up for them. But giving lots of abilities to explore and ways for a person to find a rule that they can then exploit and apply everywhere else and let it generalize, so that it can carry over to new tasks. So when Carolee, Natalia, and I actually looked at practice with one of my clients, we looked at a ton of videos, we could really tell, and we could see where we excelled in exploration, and sometimes where I was really maybe too directive and didn't give them as much chance to explore. And this is very eye-opening to me. I mean, how cool to have Carolee watching videos of you treat and giving you feedback on it. It was so awesome for me. It really brought an awareness to me of what learning quality somebody might have and how I can set up treatment for exploration. So that was number 4. And finally, number 5, maybe what I'm most passionate about, but at one point during our weekend, Carolee Winston said, let's just get rid of the word plateau. Like, hate that word. I have always hated that word. And I felt like the whole room of all of these, by the way, great, just amazing physical therapists, makes me so happy to be part of this profession. I felt like the whole room wanted to just stand up, clap, say amen to that. And this was one area, honestly, that I got to dive into as part of the presentation, and something I see every day when working, especially in the outpatient setting and in the wellness setting where people are coming for lifelong exercise. And maybe you've heard this too, is like a patient was in rehab or even in outpatient rehab, and they say, oh, they discharged me because I plateaued. And I just like to stop saying that. There really is no plateau when it comes to stroke recovery, when it comes to neuroplasticity. What we need often are other methods to drive that recovery. And maybe it does mean they need a different setting, and it's very appropriate to discharge them, but they're not done. They're not done with recovery. And I just, I think there's a lot of hope for further recovery. And one huge area that's really recognized, especially in talking to all the clinicians at this course, is this, in many communities, the ability to transition from rehab to other levels of service or be integrated into the community. For example, there are not a lot of community-based exercise programs that are actually linked to outpatient therapy. And there were a few things that were found in the literature, and actually a lot of like great outcomes. Dorian Rose has worked with Brooks Rehab and the YMCA to create a really great program, but it's just not enough because every community needs them. It's one of the reasons Re+active started our wellness program, so that we had a clear integration between physical therapy, personal training, exercise, lifelong health, but we really, really need more. And I wanted to share one really great resource. Canada, this came up throughout the weekend actually of teaching this course, is Canada has some amazing resources. And there is a program developed and led by a really prominent researcher as well. It's called the FAME exercise program. And I'll put a link again in the comments. What's really great about it, it's been researched, great outcomes, people love it, and you can get a manual with the whole entire program and start it yourself. And it's an excellent manual. So I highly recommend that. It's fameexercise.com, but again, I'll put a link in for you. But I think more of us need to help build these community relationships, start them ourselves, so that we can help with this lifelong recovery process, because there is no plateau. So there you have it, my 5 take-homes from a very intense weekend, testing and driving actual recovery instead of compensation, new interventions that are on the roadmap that drive recovery, new interventions that are not even ready for prime time, but testing and treating the autonomic nervous system, exploring and helping our patients explore and exploit for motor learning, and there is no plateau. I would love any questions, comments you have, and would love to hear from you. We do have our Schmidt Movement Disorders Fellowship learning module coming up next week. Erin Gallardo is going to be joining us, and she is going to be talking all about freezing of gait in Parkinson's. That's going to be sure to be a very good one. And our movement disorder fellowship, the application is open. So if you're interested in learning with us, joining us next year as our 5th fellow, we would love to hear from you. You can email me directly. The application's online as well. And yeah, can't wait to see you again very soon. If you found this content valuable, please share it with anyone else you know. And thanks for tuning in.